So today we have Dr. Kelly Gurka, and she joined WVU in July of 2010 and is currently Assistant Director for Education and Training at the CDC-funded WVU Injury Control Research Center, member of the Clinical Research Design, Epidemiology, and Biostatistics Core of the WVCTSI, serves on the Science Committee for the Society for Advancement of Violence and Injury Research, and is Assistant Professor in the Department of Epidemiology. She earned an MPH in Epidemiology at the University of Alabama at Birmingham, after which she served as a maternal and child health epidemiologist in the Alabama Department of Public Health. She then earned a PhD in epidemiology with an emphasis in injury prevention and control from the University of North Carolina, Chapel Hill, and was the recipient of the 2007 Susan P. Baker Student Paper Prize. Dr. Gurka conducts research related to workplace violence. In addition, she is interested in prescription drug misuse and abuse, as well as sports-related injury. She is currently the WVU Consortium Principal Investigator for a clinic-based prenatal education intervention for breastfeeding and the Principal Investigator on a study investigating the feasibility of an opioid overdose prevention program with take-home naloxone in southern West Virginia. Furthermore, she collaborates with researchers at the National Institute for Occupational Safety and Health on workplace violence projects, as well as clinicians in the Department of Behavioral Medicine and Psychiatry. Thank you, Dr. Gurka, for joining us this morning, and she will be giving us a nice overview of case control studies in clinical research.
Thank you, Michael, for that introduction. So as Dr. Gurka mentioned, I'm going to be talking about case control studies this morning, which is probably something that you're all familiar with and know something about, but I'm going to talk about some pitfalls that clinical researchers in particular tend to fall into and how these are actually a little bit easier to do in clinical settings when you have a captive clinical population than a population-based case control study, perhaps. So several learning objectives that we're going to move through this morning. Identify basic design features of a case control study. Learn the indications for conducting one. So when is the situation good in which you would want to conduct a case control study? Recognize the advantages and challenges of this study design, which there are several of both. And then appreciate the role of observational designs in clinical research. So, as you heard, I am an epidemiologist, so full disclosure. I don't tend to speak in terms of predictors, independent and dependent variables. I speak in terms of exposures and outcomes. So when I'm talking about an exposure, I'm talking about a risk factor perhaps that you're interested in investigating, a protective factor or a treatment. An outcome may be a disease, or it could be something else like an injury or a health-related state, for example. So I just want to make sure that we're all on the same page in terms of jargon. So there are kind of two categories of study design with which we're familiar when we're talking about doing human subject research. And the first one is experimental design. And so with experimental design, we're all familiar with the randomized controlled trial. And that's often considered to be the gold standard in terms of identifying causal relationships between some exposure and some outcome. The second class or category of designs that we have are the non-experimental ones, which we call observational. So rather than the investigator assigning an exposure to someone, having control over what their exposure level is, we just observe what their exposure is and how that might be related with the outcome. So the problem with RCTs, in spite of the fact that they are the gold standard, there are some limits to their applicability. So one of the things is that exposure has to be assignable. So either logistically or ethically, we have to be able to assign people to a certain exposure contrast, for example. We can't always do that. Second of all, these tend to be very expensive to do. And so in order to do them, we have to have enough clinical or scientific evidence, a big enough evidence base, so to speak, in order to be able to design this effectively and get someone to want to spend the money that it costs to do one of these, right? So we don't do these as a first-line approach to looking at some exposure outcome association. And then with a lot of the exposures that we're interested in, we can neither do harm nor prevent some good outcome from our patients So it's oftentimes that we can't tell someone, okay, I need you to go and smoke 4 packs of cigarettes a day for the next 20 years, and then I'm going to see what that does to you. Because we have enough evidence to suggest that smoking is not healthy, therefore we can't go tell our patients to do that. So these just aren't always an option for us. So that leaves us with observational designs, and often these are conducted when exposures are neither feasible or ethical, which are the two things that I just talked about a little bit. And often also, I mentioned this, when the evidence base is limited and there's additional information that we really need to plan an effective trial, we start off with these observational designs in order to get enough information where we can effectively plan a scientifically sound trial. So amongst those observational study designs in epidemiology, we have two sort of classes of designs that we talk about, and the first is descriptive. So, epidemiology is both the distribution of diseases in human population, and it's also the determinant. So we typically use these descriptive studies to talk about distributions of outcomes or health-related states in the population. So these are your case series, your cross-sectional studies, your ecologic studies, where we want to know what proportion of the population has some sort of outcome, and maybe what are the distributions of some exposures that we're interested in anyway. And we often consider these to be hypothesis screening types of studies, where these are not going to tell us anything about causal relationships. They're going to generate hypotheses or screen hypotheses that we then want to use the second class of studies for, to answer some of those questions we have about causal relationships. So analytic studies are the second class. They utilize comparison groups to measure associations between exposure and outcome. So with a case series, for example, we might see some exposures that are fairly prevalent among our cases, but without a comparison group, we don't really know if that's associated with the outcome or if it's just that that's the baseline rate of that particular exposure in the population at large. So we have to have that comparison group in order to make some inferences about possible associations. We use these analytic studies to do that second piece of epidemiology, which is identify determinants of health outcomes. So we're all in the business of prevention, right? We want to be able to say what exposures are associated with what outcomes, so that we can then say, maybe if we reduce the exposure distribution in the population, we will also have the outcome of reducing the outcome distribution in the population. In clinical settings, we want to treat our patients, and hopefully we want to do prevention in clinical settings as well. But once people have some sort of health outcome, we want to know what effective treatments we can use to hopefully improve that outcome, either curing it or treating the symptoms. So there are links between these designs. So you start off with that gold standard of the randomized experiment, and that leads to the observational cohort study. So if you think about an RCT as a cohort study, where you have, in the simplest case, 2 arms, maybe a treatment arm and a control group, and that might be standard treatment, or it might be nothing at all, depending on what your research question is. And that you can see that in this particular case, it is following a group of people forward through time, looking to see whether they develop the outcome or not. In this particular case, what makes it experimental is the random allocation of the exposure. So here you have your study population. Up here, you randomly allocate whether they get into the treatment group or the control group. And again, this could be standard treatment, it could be nothing, it could be some other alternative treatment. Okay, and then we follow them forward through time. We look to see, do the people in the treatment group improve or do they not improve? And in the control group, do they improve and do they not improve? Why do we do this? Because we want to compare the rates to see if improvement is greater in the treatment group than in the control group. Okay, so this looks just like a cohort study if you take away the randomization and change the names of this from treatment and control to exposure and some exposure contrast. Okay, so it's the same concept. We're going to enroll a group of people, we're going to figure out what their exposure levels are, and we're going to follow them forward through time. Okay, so the cohort design is considered, the prospective cohort design is considered to be the most sound of the observational study designs. Okay, but from this, we can see the differences from the randomized control trial is that exposure is not randomly assigned. Well, this is where all the trouble starts, so to speak. So because we can't randomly assign exposures, because we're just observing them in the population. This is where we have to worry about bias such as confounding. And you have to worry about information bias and selection bias in those other studies, but confounding is now a huge issue for these kinds of studies. So we have to decide, is the differences that we see between the exposed group and the unexposed group with regard to the outcome actually due to the exposure of interest, or is it due to any of the other things that could be different about those two groups, okay? We didn't get to randomly allocate exposure. So what is it about people that are exposed that might also be associated with the outcome that leaves them in the exposure group, okay? We do, however, classify subjects on the basis of exposure status, just like in an RCT. And the fundamental comparison is exactly the same. What's the incidence of the outcome in the exposed versus the incidence of the outcome in the unexposed? Okay? And again, this is the simplest case where you only have two exposure groups, and it's you have the exposure or you don't. We could be talking about different levels of exposure. We could be talking about having, male versus female, for example. It's not that you have female and don't have male, or don't have female, right? So here's a subsection of a cohort. So these dots represent people. So there's 18 people in this subsection of this cohort. And here we have time. This is 0, and we're ending some follow-up period. Now we can take these 18 people and we can decide whether they're in the exposed group or the unexposed group. So the solid circle represents people that are in the exposed group, and the open circle represents participants that are in the unexposed group. Then we take and we follow these folks through time. So we trace them over time and we see what happens. So you can see in participant 1 here, we follow them forward through time. They're not lost to follow-up, but they also don't develop the outcome of interest. Okay? And then we do this for every single person in the cohort. This person here, at whatever time point this is, they've developed the outcome of interest. Okay, so this is what we do in cohort studies. We trace people through time. We wait to see whether they develop the outcome of interest or not. Down here we have unexposed folks, and we have one person with the outcome, and we follow them through time. So there are limitations to cohort studies, just as there are limitations to randomized controlled trials, however. These studies tend to be inefficient for rare diseases. If we go back to this slide, here I have 18 people and I have 3 outcomes. That's an outcome with a really high incidence, 3 out of 18. You can imagine if you had an incidence of something that was 1 in 1,000 or 1 in 100,000 or 1 in a million, you're having to trace a whole lot of people forward through time in order to get a meaningful number of the outcome in order to do an analysis to see whether the exposure has an effect on the incidence of that outcome. So these studies don't work particularly well for rare outcomes. They're also inefficient for diseases with long induction and latency periods. So again, this period of follow-up time here, if you are studying a disease that takes 40 years to develop after you've had some exposure, you're going to be following patients for a really long time. This is going to be a really expensive endeavor, and you're probably going to have some problems with loss to follow-up because you're going to lose people over that 40-year period of time. When you do have loss to follow-up, if it's not completely at random and it may be associated with the outcome that you're trying to count, then the estimates that you come up with are going to be biased. So this is another problem, is that as you go forward through time, you lose people out of your study, then your estimates are suddenly going to become biased. And these are probably the most expensive of the observational designs, because you can imagine you have to enroll a large number of people into the study, you have to maintain a study staff who has to keep in touch with them, and you have to have repeated assessments with them so that you can assess whether they do or do not have the outcome. Okay, so this gets to be pricey. So why have I been talking to you about randomized controlled trials and cohort studies for the last 15 minutes when this talk is supposed to be about case control studies, right? So there's a link between case control studies and cohort studies. So you can think of, whoops, it'd be helpful if I didn't advance. You can think of all case control studies as being nested in some cohort, okay? So case control studies were designed in order to deal with some of those complications that arise out of cohort studies. So even if you're doing a population-based case control study, you can think of the population as being that cohort, okay? In our subset here, example, you have the 3 cases here. So time has already passed. Now I'm the investigator hanging out over here, and I'm looking back in time, and I'm saying, oh, I have 3 cases of this particular outcome, okay? I can take those and find information out about them from the past in terms of their exposure and classify those cases based on their historical exposure experience. Then I can take a sample of controls. So maybe we select this control, and we select this control, and we select this control. And I can take just that sample of controls and compare their exposure experience to the exposure experience of the cases. So case control studies are not inherently an inferior design to cohort studies. They actually gain efficiency through that sampling. So it's the same population, but rather than tracing the entire population forward through time, what you're doing is you're taking a sample of those controls to represent the exposure distribution of the base population, okay? So again, this is just a subset, but imagine if you could see an infinite number of people in the population. Well, not infinite, but the number of people in the population. Here, you're just sampling from this group instead of following everybody, okay? Now, it's easy for me to say that we're sampling. The challenge comes in how you do the sampling. Okay, so if you look at a case control study design, here we have the population of interest, some group of cases. Ideally, you would have all of the cases in the population, but in practice, we're often working in some subset. I mean, if we care about what this exposure does to the human race, we're not going to be getting every case in, the entire world. So we're, working in some geographic regions. That's why I have sample up here. Then you're going to have some group of controls, which are a sample of the population from which those cases arose. That's really critical, that these controls have to represent that base population in which these cases occurred. Okay? And then we look and say, did they report the exposure or did they not report the exposure? Okay? Ideally, you would have some sort of record that would tell you about exposure, or maybe you would have exposures that didn't vary with time, because we're going to talk about in just a minute one of the challenges here with asking people about their historical exposure after they've already developed the disease. Okay, so case control studies are also an observational study where exposure is not randomly assigned, so they're the same as cohort studies in that regard. But the subjects are now selected on the basis of their outcome status. So you first identify some case series. You figure out what cohort, so to speak, they came from, what population from which those cases arose, and then you take a sample of that population. The fundamental comparison, however, for this study is the same as it is for the cohort study. You're looking to see among the exposed and the unexposed what is the incidence of the outcome, okay? But what we're doing is we're taking those controls and they're going to represent the exposure distribution for the population, and then we're going to compare to that the exposure distribution of the cases, okay, and see if they differ. So what you ideally want to do is the same thing, but you're kind of doing it in reverse. I emphasize kind of. So your controls, they're used to estimate the exposure distribution of the source population. So in other words, in a population cohort, they're a sample of that group. And they must be selected independent of the exposure of outcome. So, no, they must be selected independent of exposure status. So because you're trying to represent the exposure status of the population, you don't want to have a sampling mechanism in which it is dependent upon whatever your exposure of interest is. So for example, if you want to do a case control study where you're looking at whether medications are a risk factor for falls and hip fractures, then you don't go to the prescription records of the hospital where you identified your cases of hip fracture and sample from the prescription records in order to assemble your control group. Because your exposure of interest is their medication history. If you use prescription records, then you are inflating the amount of prescriptions that your control group has. Does that make sense to everybody? Okay, so you have to make sure that however you select your controls, that it's independent of their exposure status. Now the challenge here, of course, is that, you know, if you're doing a population-based study, you need a census, essentially, ideally, of the population from which the cases arose. Well, we don't often have that census. So we did a case control study in North Carolina where we were looking at risk factors for workplace homicide. We did have the American Business List to go to, which is a census of every operational business in the state of North Carolina. So that makes a really nice sampling frame. You can go in there and you can say, at the time the case occurred, I'm going to randomly draw a control to match on time with that case, okay? And that will represent the exposure distribution of the source population of workplaces in North Carolina at the time that the case occurred, okay? Unfortunately, for population-based research, we don't often have that nice, neat sampling frame. I think part of the confusion with case control studies is in part due to the unfortunate, perhaps, use of the word control. So I think we tend to get our thinking confused because we associate the word control in an experimental study with the idea of a control in a case control study. The problem there is that in experimental studies, control refers to the exposure status, right? So I'm going to treat you with some treatment and I'm going to have a control group. That is the exposure. We want to see, does this treatment have an effect, and I'm going to compare it to this control group. In a case control study, the controls are the non-cases. And so you have to keep that straight in your head in terms of not getting confused about the thinking, because we often want to say, oh, I want my cases and controls to be as much alike as they possibly can be, so that the only difference between them will be the exposure. Well, remember, they need to be a sample of the population from which the cases arose. This has already happened in time, and so we need to know what is the natural exposure distribution that occurred in the population, not can I get two groups that are as similar to one another as possible. And this is what we will often refer to as the TROHOC fallacy. So you'll notice this is cute, right? It's just the word cohort backwards. So in a case control study, we are comparing cases and controls, so it is often thought that the controls should be as much like the cases as possible, except with regard to exposure. Well, that thinking is flawed, okay? Because this has already happened, okay? Some exposure occurred back in time or didn't occur for your population. We're following these groups forward and saying how many developed the outcome and how many didn't. Now, here you are, the researcher, with a fantastic idea. At this point forward in time, you identify your cases, you identify your controls, and you want to look back and say, what was their exposure distribution? This here needs to be what naturally occurred in your source population, not what I engineer it to be because I want my controls to look as much like my cases as possible. And in fact, in doing that, you're absolutely introducing a selection bias, and you're possibly actually biasing that effect estimate towards the null, because it's likely that the people that are more like the cases are actually have a similar risk compared to the people who got the disease, and you may be leaving out the people who are more unlike them and have less risk, and so your effect estimate is going to be smaller than it would have been otherwise. Okay? So the cases do not actually need to be comparable to the controls, and you'll hear this all the time. There's this tendency to want to match your controls to your cases, okay? What they really need to be is representative of that base population, okay? So think about, from where do these cases arise, and how do I sample randomly from that population to estimate the exposure distribution of the source population, okay? So I urge you to resist the temptation to match. There are reasons to match, but you should do so sparingly. I would say with great caution. Gives epidemiologists some job security. You should probably consult one about when to do it and when not to. And usually matching it's for efficiency, it's not for preventing confounding, okay? And again, when you introduce matching, you are by definition introducing selection bias. Okay, so when do we do, let's switch gears a little bit from what a case control study is to when we conduct a case control study. So we've already talked a little bit about, if there's something that you can't ethically assign to your patients, if they're too expensive, too time-consuming. So oftentimes you're in a clinical setting, you want to know, okay, what risk factors are associated with some outcome in my particular clinic population? Or, if we started an intervention, we didn't randomize the intervention, we just started doing it, but we want to get some idea about what effect it might have. So we're just going to observe in our clinic population what effect some intervention that we've introduced might have. If you have to go back and abstract a lot of charts because the outcome in which you're interested is fairly rare, you may not have the clinical resources or the time to go back and do all of those chart abstractions. So instead what you might want to do is a case control study. So it's the same kind of thing where you have a rare outcome, maybe it's something that takes a while to develop and you have some records that you can go back in time and look at. Ideally, you have a well-documented exposure data, okay, and that a readily identifiable base. So ideally, you're going to have some census from which you can sample those controls. Well, what's really nice is that, so I'll talk about these challenges a little bit. So often a population census doesn't exist. We talked about that particularly in population-based studies. As a result, your study is very susceptible to selection bias. So you'll often hear about doing hospital controls, for example. So you have one outcome, you make those the cases, and then you pick some other outcome and you select them from the hospital for this other outcome, and they're your controls. The idea there is you're trying to mimic the source population being the catchment area of the hospital. The problem is that the cases arose from the entire population, and people who go to the hospital are not a random sample of the population that serves the catchment area of that hospital. In addition, when you're talking about places like WVU, our catchment area is wider than it might be for a community hospital. However, it's not a random sample as to who comes to our hospital from those more disparate areas of our catchment area. Those are the more severe cases. So now we're talking about lots of selection bias in terms of the sample that you've just selected to represent that base population. Okay? The second biggest challenge for these is because they are retrospective in nature, right? You might do prospective case finding. In other words, you're waiting for new cases of the disease to develop, and you enroll patients into your study quickly after they develop the outcome. The problem is that their exposures happened maybe last year, last decade, 50 years ago, depending on what you're interested in. So if you don't have a record of exposure data, then your study is subject to recall bias. So when we talk about recall bias, this isn't just non-differential problems with memory among the cases and the controls. This is a specific type of bias that happens in case control studies where you have a group of cases who has the outcome. So if you think about a group of moms who has an infant, and the infant has some birth defect, and now you're going to ask mom, okay, what were your prenatal exposures during this, or what were your infant's prenatal exposures during your pregnancy? And you're going to ask her. So now she has a child who has some birth defect that she may have her own theories about what caused that birth defect. Then you're going to go to a group of control moms who have a healthy infant, and you're going to ask her what were her prenatal exposures. You can imagine that their recollection of their prenatal exposures is going to be different, whether intentionally or unintentionally, because maybe moms with babies who have birth defects have given a great deal of thought to everything they did during their pregnancy compared to the women who had happy, not happy, all the babies could be happy, who had healthy infants. So that's the problem, is that particular bias is differential based on the outcome. Okay, so that's a particular problem for these studies. Which way did I go there? So in clinical research, however, you actually have an advantage over those of us who do population-based research, because often the questions that you have are specific to your clinical population. So you have a census of the population in which you're interested. It's everyone that's come to your clinic for a certain procedure or with a certain outcome, for example. And so you, because of the very nature of your practice, will actually have that source population very well defined. Now, of course, this clinical population is a subset of the larger population, but if your research question is related to clinical care, then that subpopulation is the population in which you're interested in asking the question. The other part is that Your exposure data, often what we're interested in is what procedures did we do to you? What treatments did we give you? Or we have other risk factors that we're interested in, such as comorbidities. These are data that we routinely collect during clinical care and put into the medical record. So you already have this historic record that you can go back to and look for exposure data. Now, the problem is, of course, that takes time and energy, right? Because you have to go back to the medical record, and even now that we have an electronic medical record, you can't just take the data and dump it into a data set and run with it. You often have to go sit in front of a computer screen and write down the data points that you want, okay? Or copy and paste or whatever. So, when you have the situation where you have a lot of patients who make up your source population, and you have a lot of cases, which is good for powering a study, then you might want to consider doing a case control study. So we're working with a group of researchers here who is interested in risk factors for readmission among stroke patients. So 2,288 stroke admissions. That's a lot of patient records to have to go back and abstract. Particularly if you have to go back and do it a second time because you didn't quite identify all the risk factors in which you were interested the first go around. Okay, you have 220 cases. So if you sampled controls from this population, which you have the census for because you know everyone that you've admitted with a stroke, then you can sample these controls. And we're looking at doing, somewhere between 444 record abstractions up to a little over 1,000 maybe, as opposed to 2,288. Okay? So this is where that efficiency comes in. You can utilize your clinical resources more effectively and have fewer records to abstract and still develop a sound study that's going to give you informative information about the relationship between some risk factors and what the risk and whether patients are readmitted. Okay? So there's a couple of advanced concepts that I'll just touch on just so that you're aware of it. This is a quote from Modern Epidemiology, which is the text that I use in my advanced methods course, and I also kind of consider it the Bible. So it's conventional wisdom about case control studies is that they do not yield estimates of effect that are as valid as measures obtained from cohort studies. This is a fairly advanced concept, but I just want to make you aware that, you always hear with case control studies, oh, it has to be a rare outcome because of the odds ratio. Well, there are actually ways in which you sample from the source population such that you can estimate these different kinds of effect estimates, so incidence rate ratios, risk ratios, or prevalence ratios. So there is a way to do these studies in which you design them such that you can estimate these factors, so that you can make some pretty nice statements about the associations. We'd have to do a whole nother talk or perhaps course on whether you could call them causal or not. And then another one that I just wanted to briefly touch on is the case cohort design. So this is an extension of the case control study. One of the knocks against case control studies is that, oh, you can only look at associations with one particular outcome. Well, actually, you can do, this is a variant or an extension of it, where you can, whoops, not questions yet, where you can sample one set of controls, right? And if you do a good job of sampling from that census, then you can use them to compare to multiple case series, depending on what outcomes you're interested in. And that way, you can actually look at the effect of risk factors on a number of different outcomes. And that's another way to gain efficiency, but without losing that ability to look at multiple outcomes. So it's just a couple of advanced things that I wanted to mention that, if you're interested in doing a case control study, you might want to talk to someone about how you go about designing the study in these ways. So I also did a study at UVA where we were looking among lung transplant patients who had a primary graft dysfunction. So we did this, a study like this there as well. And they actually work really neatly because you've got that census, and it's actually fairly easy to do. I mean, in the context of case control studies, these in clinical settings. So I think they're a really good tool that are often misused. They have some easy pitfalls to fall into, but if designed well, can really answer some nice clinical questions.